was great, and you too, David, at presenting to the health policy benchmark here. Really good job, really clear, very thoughtful, and it's so nice just to be able to say, these are the facts. We've got them. So, good job, and I know what it takes for the team to pull that one together. The team effort, thank you, it's terrific.
Thank you.
Okay, we are going to open up with request for approval of the minutes. So we'll get to discussion or stuff, any approval?
Small item. At the very bottom of page 2, the last item, also reads that the statutory definition of total healthcare expenditure does not fully capture, rather than may not. That's pretty solid.
Doesn't
It isn't intended to.
where are you?
Sorry, last line on page 2 of the minutes.
Oh, may not fully capture the actual, oh, I see what you're saying. I'm sure you didn't say may not. I'm sure you said does not. With that
All
correction.
these 3-letter words versus 4-letter words.
Any other corrections to the minutes? Okay. Hearing none, I have to go to roll call because, is she on now?
Yes, she's on.
She's on, great, okay. Make sure we get everybody.
All right.
Okay. You can hear us, okay?
Yep, I'm good. Thank you.
Terrific.
Alex, can we split just the image so that we can see Dana?
Yeah.
I think her camera's off, that's fine. Oh, it is, okay. I didn't mean to spot her.
Thank you. It's confusing to look at ourselves. Okay, I'm gonna just go down my list. Brent,
Yes.
Adriana,
Yes.
Niels,
Yes.
David,
Yes.
Dana. Dana, you're on.
Yes.
Thank you. Eliza,
Yes.
Sandy, you're here. Hi, Sandy. Yes.
Yes.
Jean
Yes.
and Alan.
Yes.
With the correction. Terrific, so approved. We have a terrific agenda for today, with a lot of good topics, and we're gonna start with a review of the annual report, and that's gonna be by Molly, who's gonna be coming up, I think. Great, we're gonna spend a fair amount of time, by the way, on the affordability strategy, and then the CHIA priority areas. Those are the 2 areas in particular where I think the team is looking for council input. So we hope we'll have a robust conversation around those 2. And then an executive director's report on a variety of topics. So you can start, Molly.
Awesome, thank you. Hi everyone, I'm Molly Bailey. I'm a manager on the health informatics and reporting team. So Laura, did you want to do some opening remarks? Do you want me to
Start right in.
Perfect, thank you. So quarterly annual report, CHIA calculates total healthcare expenditures, or THCE, and measures the Commonwealth's performance on a per capita basis against a healthcare cost growth benchmark, which is set by the Health Policy Commission. And for calendar year 2023, the benchmark was set at 2.3%. So I'll start by reviewing some of the top line total healthcare spending figures. So in 2023, THCE increased to $78.1 billion, equating to $11,153 per capita, or per Massachusetts resident. This then puts the per capita growth rate at 8.6% for the 2022 to 2023 performance year, which is more than double the healthcare cost growth benchmark. This 8%, this 8.6% growth rate is the second highest growth rate since CHIA began measurement in 2013, second only to that in 2012. Second to only that in 2021, when there was a sharp rebound in healthcare spending in the wake of the pandemic. So taking a look at this graph breaks down spending for what we consider the major components of THCE. In between the bars, you'll see the aggregate spending growth in that top number in the bubble, and then the change in membership in that bottom number in that bubble. We show, on the right side column, we show the per member per month growth rates, which accounts for both the spending and membership. On the right-hand column, and this is to account for the dynamic shifts in membership and enrollment during this period when looking at each of the insurance category spending numbers. So starting at the bottom, Total commercial spending increased 7.2%, while membership continued to decline, resulting in an 8.9% increase on a PMPM basis. Next, Medicare spending increased 7.1%, while membership remained relatively stable, resulting in a 6.3% PMPM growth rate. And then Mass Health spending grew 14.8% in 2023, with a 4.4% growth in enrollment, equating to 10% PMPM. However, it's important to note that this Mass Health growth was largely driven by $1.5 billion in new supplemental payments to hospitals to support key initiatives, such as performance-based incentive programs focused on quality and health equity and Medicaid hospital base rate increases. This $1.5 billion in new supplemental payments in 2023 were financed by a combination of an updated hospital assessment and federal matching funds, which were then allocated by Mass Health. So if we exclude that $1.5 billion in new hospital-based supplemental payments, Mass Health spending would have grown 7.2% or 2.7% PMPM. On the next slide, we're going to break down THCE by service category, which combines spending across commercial, Mass Health, and Medicare, and reveal some of the major cost drivers. So hospital outpatient and hospital inpatient at the bottom of these bars had a combined growth rate of 6.3% to $26.6 billion in 2023, representing the largest share of THCE. Pharmacy spending net of prescription drug rebates saw an accelerated growth rate of 10% in 2023. And finally, I'd like to call out that non-claim spending at the top, which experienced the fastest growth rate, increasing by 40.6%. So this non-claims category includes spending for capitation payments, care management programs, and those Mass Health supplemental payments. Also, this category includes payments made for Mass Health's new primary care subcapitation program, which began in April of 2023 and shifted payments from claim spending primarily from the physician category to the non-claims category. So in sum, non-claims, hospital outpatient, and pharmacy were the top drivers of spending growth, with each category increasing by more than $1 billion in 2023. So now we're going to switch to our section on healthcare affordability, with the goal of translating these high-level numbers to better understand how these trends impact individuals and employers on the ground. So this slide here provides a 2-year look back to put healthcare spending into a broader affordability context. And at a high level, when we look at the cumulative growth of healthcare costs borne by individuals and employers compared with economic metrics, premiums in the orange and member cost sharing in the dark blue increase faster than Massachusetts wages and salaries and regional inflation, which are in the gray. Also of note, paid medical claims, the lighter blue at the bottom, which represents the portion that plans are responsible for paying, grew more slowly than member cost sharing, indicating that healthcare costs borne by individuals and families grew faster than the costs borne by health plans. We also this year put these figures into a broader context and identified that healthcare affordability concerns are further pronounced and compounded by growth in spending for other household necessities, such as food, housing, and childcare on the graph. So on the next slide, we're going to take a look at the fully insured premium trends. So this slide breaks down the premium growth rates and PMPM dollar amounts by market sector. So at the top, we have the individual purchasers, and then the various employer and sponsor insurance market sectors. You'll see at the bottom in orange that the statewide average premium in the fully insured market increased 6% to $631 PMPM. However, premium trends varied by market sector, with the unsubsidized individuals and small groups experiencing the fastest growth rate, while the mid-sized group had the highest premium amounts. So on this slide, we're looking at member cost sharing, or what a member spends out of pocket per month on co-pays, co-insurance, and deductibles, also on a PMPM basis. Overall, the 2023 cost sharing trends show a similar story to that of premiums. The average cost sharing amount, shown in orange at the bottom, increased 5.9% to $68 PMPM. But cost sharing grew the fastest among unsubsidized individual purchasers and the small group and mid-sized group market sectors, which we know can largely be attributed to higher enrollment in high deductible health plans among these sectors. So this next slide on affordability takes a look at the impact. Oh, is there a missing one? Apparently, all right, we'll jump ahead. All right, so finally, we'll move into hospital finances. Click to the next slide. And here we're looking at the hospital profitability trends from hospital fiscal year, or HFY 2019 through June of 2024, and reflected by total margin, operating margin, and non-operating margin. So the data for 2024 is not a full year. However, data through June is often representative of what the hospital's financial position at the close of the fiscal year will be. So we take a look at total margins, which is the dark blue on the slide. This includes both operating and non-operating. So the non-operating can be thought of as investment activities by the hospital. The statewide median total margin increased by 6.4 percentage points to be positive in hospital fiscal year 2023. However, the data through June of 2024 shows total margins trending back downward, but still remaining positive at 1.4%. When we took a look at operating margins, so this is the typical patient care activities of a hospital, the statewide median margin also increased from a negative 1.3% in 2022 to a positive 0.2% in 2023, so the orange line on the graph. However, the total operating margins are decreasing back to the negatives in 2024, and only 25 of 58 hospitals are reporting a positive operating margin. The median non-operating margin, so again, those investment activities, has steadily increased in recent years. And that concludes the section on the annual report.
So first, questions.
Yes.
I just have a brief question. When you say member cost share, is that the copay and the deductible, or does it also include the payment of their share of the premium?
It does not include premium, just the co-insurance, copay, and deductible.
Thank you.
In that spirit, do we have available data on employee share of family or individual premium by the different group sizes?
Mm-hmm. Yeah, so this comes in through our premiums data collection, where premiums are reported in aggregate. In the MHIS, so the Massachusetts Employer Survey, sorry, the MES, that team does break down the individual and family premiums by employer and employee share. And I think it's pretty consistent at like 24 to 26% of the employee.
And it breaks it down at the market sector
Yes,
level,
yep,
right?
market sector level. And I don't know if in the report, but I know they have that data available. I don't know how detailed it gets in the report, but it does have the individual plus one, and then a family premium amount in the portion of, who's responsible.
By employer size?
Yes, I don't know if it's in the report, but I think they have the underlying data available.
Because combining the two, the average out of pocket and the average worker family share of the premium, might be a good complementary or additional measure of affordability.
I know, I'm not sure when the publication date, Lauren, as you might have to jump in, but I know we are publishing kind of a companion piece where we take a look at like individual experiences, or like pretend individual experiences of affordability. And I think that's part of it as well, like the employee-employer breakdown.
Yes, in the companion piece that Caitlin will speak to in the next section, does have sort of profiles to illustrate the various experiences of individuals, families, and the like. But I believe the data that you're asking for is in the Mass Employer Survey report. That the last one was in December. But we can confirm that integration of premium, cost sharing, and employee share is all in there.
Yeah, I think we took a look at, we brainstormed adding a page of breaking down the premiums by employer share, but because it was so consistent across market sectors, there wasn't really an applicable finding to create a whole page. I think in the intro section, we added that, it's typically 24 to 28% for the employee share. So it just wasn't very notable of a finding at this level, at least.
But aren't how does total premium vary with number of employees in a company? Is it the total?
This is
premium?
aggregate,
So go
so
back to the premium slide.
Yeah,
Yeah, so that's aggregate, but I think we cite the range in the annual report.
Yes.
It's somewhere around 24 to
24,
28.
yeah, and we did have a page where we started to look at the, you know, the
right.
percentage, but because it's so consistent across employer sectors, there wasn't any key findings to come from it.
Yeah. I was thinking of the dollars rather than the percentage.
Well, because the total
Yeah.
dollars are also pretty close, it was the total dollars were also within a few of each other as well. Yeah.
Good.
I did have a question on the slide with the healthcare expenditure, the per capita percentage. You had talked about the one-time input costs related to mass health and how that affected, and you had said if you took that out, what the effect would be on the change just for mass health. Do you have the numbers for what the actual THCE and the per capita percent would be if you actually also took that out?
It's either 6.2 or 6.3. It just impacts, it drops it down almost a little over 2 percentage points from the 80.
Terrific. And again, really, it was a great presentation, and I'm sure lots of people are reading it, and
I hope so.
It's also worth noting that this is just a sliver of sort of the key findings, but we wanted to sort of highlight some of the key findings that, you know, we received that most questions and attention on, both at the hearing, but I think just in general, the focus really is around affordability, the growth in spending, as well as the hospital financial performance, just in light of all of the ongoing trends that we're seeing, including in the aftermath of Steward.
thank you. It's a great segue to affordability.
Lauren, do you want to give a little bit of a framing for affordability discussion?
So I think in this next section, we wanted to dive a little bit deeper into the topic of affordability. As Molly presented, you saw some of the annual metrics that we're looking at, but we've been working in close collaboration with the Health Policy Commission to think about how can we really drill down even further on some of these affordability metrics with the goal of translating, again, these high macro numbers, expenditure numbers, to a more person-centered level. Because yes, we can say that our system as a whole spending shouldn't grow by more than the benchmark 3.6%, but we know that affordability challenges disproportionately impact certain populations and demographics. And so I think part of this effort is to look at affordability and spending trends from the person level view, and report out, in addition to the macro, reporting out at that with that lens in mind. So with that, I'll turn it over to Ashley to sort of go through what we currently are collecting. But we really want to hear from the council and get your feedback on what are some of the additional metrics or data that we should be collecting to help kind of paint the comprehensive picture that we're looking to highlight. So with that, I'll turn it over to Ashley.
Great, thank you, Lauren. So we've been talking for some time now about healthcare affordability challenges in Massachusetts. It comes up every single year. And the slides that we've just seen really illustrate the urgency of this topic, and it's something that we really feel that we need to address. And so for the next few minutes, I'm going to outline what CHIA is currently doing in terms of our affordability reporting, and also preview some new work that we're working on that we hope will deepen the conversation. So on this slide, the first data source I'm going to highlight is the Massachusetts Health Insurance Survey, which is a biennial survey of households across the Commonwealth. If you get confused about that like I do, that means every 2 years, not twice a year. So we are able to stratify the results from the survey by race and ethnicity, health status, income, and other demographic characteristics. The MHIS covers many topics, including questions about unmet healthcare needs due to costs, problems paying medical bills, family medical debt, behavioral health care that was paid for entirely out of pocket, and residents who report spending a high share of their family income on out-of-pocket expenses. An advantage of using survey data compared to what the insurers can tell us is that this reflects services that are not covered by medical insurance, as well as the experience of individuals who are uninsured for part or all of the year. Next slide. The second survey that covers affordability topics is the Massachusetts Employer Survey, which Molly mentioned a few minutes ago. And it was most recently published last year. The primary stratification is employer firm size, and some measures also highlight the experiences of lower wage firms, which are those where at least 35% of employees earn the equivalent of $17 an hour or less in 2024. The MES gives us insight into the percentage of employers who are offering health insurance, the premiums for both family and single plans, employer contributions to HRA and HSA savings options, average deductibles, out-of-pocket limits, and copay amounts, and strategies that employers have used to control healthcare costs, which gives us very important context for the 90% of the market that is provided through employers. Next slide. And then finally, CHIA sources affordability metrics from a variety of insurer-submitted data, including both aggregate submissions and the APCD. Most of these were just included in our annual report, including enrollment in high deductible health plans, premium rates and growth trends by market sector, member cost sharing, including copays, coinsurance, and deductibles, the affordability and context graph that Molly showed us, which displays increases in healthcare costs alongside growth in other household expenses, inflation, and wages and salaries, and a comparison of THCE growth with member cost sharing growth. And we also included average commercial member cost sharing amounts for top prescription drugs in our prescription drug use and spending report last year. Next week, CHIA will release what we're calling our companion piece to the annual report, which aims to show the impact of rising premiums and out-of-pocket costs on different profiles of Massachusetts residents based on their individual health coverage, income, and other household expenses. The piece hopes to make this data more real and illustrate the variation underneath the averages and the high-level trends that we cover in the annual report, putting a name and a face to these numbers. So on this slide, I'm going to talk about several enhancements and additions that we're planning to our current affordability reporting, which we hope will support policymakers in understanding the scope of the problem and the populations most impacted. The 2025 MHIS, which is currently in the field, includes refinements to questions on medical debt, such as expanding the definition to include medical bills that families are unable to pay at all, asking about the types of medical services that led to that debt, and the consequences of medical debt and problems paying bills. We're also updating our prescription drug use and spending report to spotlight drugs with high member cost sharing. Additionally, we plan to look at the chronic condition drugs that are available at no cost sharing for Connector Care members and understand what members in other commercial plans are paying out of pocket for those drugs. We're currently developing a new report on oral health utilization and spending, which will be discussed in more detail at an upcoming council meeting. This will include a focus on member cost sharing for members with dental insurance, as well as taking a closer look at survey results on residents delaying dental care due to cost. Finally, we are exploring enhancements to the aggregate premiums data collection, which is one of the data sources used in the annual report. Collecting premiums and member cost sharing data, including deductibles, with geographic stratification would support reporting on regional disparities in healthcare affordability. Currently, we have it all statewide. So that's the high-level overview of where we are with our affordability reporting, where we're looking to move. But before we get too far down this road, we want to check in with the council and solicit your input. So here are some questions that we'd like to tee up for your consideration. Are these the appropriate data points to support the policy? And is there additional data that CHIA should consider collecting? Are there other analyses and reporting that CHIA can do to advance our understanding of healthcare affordability challenges and inform targeted solutions? And finally, what perspectives and organizations should we consider in our affordability strategy?
That was an open questions.
Pick any of those or suggest your own.
Thank you.
This is a small thing, but when it talks about the behavioral health care paid entirely out of pocket, it seems, I'm hoping that from an analysis point of view, you're looking at all the levels of cost sharing, people that are paying entirely out of pocket, people that are paying a lot out of pocket, people that are paying very, just it probably isn't right to only look at people that are just, that are having to pay all of it out of pocket, because it can be a lot to pay out of pocket, even if it's some of it paid by somebody else.
Understood.
I think right now we collect member cost sharing for behavioral health, where they do have insurance, but we know that there's a whole segment out there that, because their insurance doesn't cover the service or a given provider, or the providers just, the individual says it's easier to go see this provider, pay fully out of pocket and not deal with the use of insurance. That I think that's an area that it's a little bit harder to get data on, because all of our aggregate data is coming from payers. So it by virtue of how we get the data, it's those attached to getting services that are either covered or partially covered by the health plan. I think what we're trying to move towards is getting better line of sight into those that aren't using insurance at all to pay for the behavioral health services and the prevalence of it.
That makes total sense. Then that's a really important pool. It's just in the analysis part, you want to just look at it both together.
Oh,
right?
yes,
Yeah.
of course.
I guess my question would be the definition of affordability, well, more a definition of what falls into the bucket when you're looking at it, thinking about access, because, and I feel like I'm always saying in Western Mass, but, do things like transportation, there are people who don't go places because they can't afford the gas, or in cases of folks who are uninsured, as you talked about, they have to come to either Worcester or Boston to get services because there is nothing in Western Mass, and paying for those, paying for that gas or paying for those, what's the word, rideshare services is a barrier to being able to come out. And so these are like, do they fall into the bucket or not? The other piece is about respite, and, they are costs that people are bearing solely because of the need for medical care, but they're squishy, and so would that count? I don't know, and I don't know how you can collect those, but just those are the kinds of affordability things that people can factor into making decisions about how affordable is it for them to go to get services.
Just to reinforce one aspect, federal data show that only 7% of home health costs are paid out of pocket. And that's totally unbelievable.
Yeah.
So
Yeah.
what's missing?
And so I don't know if that falls into your definition of, within this.
We certainly look at home health sort of utilization, and it's one of the sort of spending categories. My guess is it's a definitional challenge.
Exactly.
Of what are we defining? But I think to the question around transportation, we can make sure that we ask flavors of that question in our NHIS survey, looking at what are barriers to care. I don't know if transportation is one of the particular questions, but it's has regional relevancy, and it's something that we can bring back and factor into the next one if it's not already measured.
Maybe NHIS, I just want to add that we do ask in terms of barrier to care, access to care. We do ask whether transportation is an issue in terms of not seeking medical care at a doctor's clinic. So that measure is included but usually we put it at the access.
Right.
content versus thinking about it much more broadly in terms of encompassing affordability. We could definitely take a look at that measure.
Yeah, I mean, I just know that gas cards are a big thing to increase access. And so therefore it's an affordability issue because of the fact that it has to be basically cash to get somebody to go. Right. But that's a barrier. So, but I don't know.
A fair point, and maybe we can just reframe the question, so it's not just barriers to access, but it's an affordability, to tease out, is it affordability of transportation or is it finding transportation itself?
Right, because it's all.
I think we can learn a lot from the survey. There's a lot of information, but I guess my question is, do we have any sort of hypotheses around sort of the significant findings that could address affordability challenges? Because, you know, it's a little sobering because we've been working on this for many years. We've tried value-based care, cost transparency, consumer-driven benefit design, you know, all kinds of things, a whole, you know, wholesale payment reform. But we're still looking at very high cost trends, and it's not even very clustered. You cannot blame GLP-1 on everything just yet. So what is it that we can do that, you know, ideally, you know, the survey will be a little bit targeted, so that we can test a few hypotheses that could, you know, get to not just sort of very specific target issue, but just sort of big picture wise, how do we go from 8.6 to 3 point? Yeah. It's a bigger question. It's probably more than just survey. My concern is, you know, are we able to leverage the survey to get closer to what we need to get to?
If I can word that a little bit, because I think it's really interesting point is, we know it's really unaffordable for lots of people. We've been doing
Yeah,
that, we've looked at it, et cetera. So maybe asking the people that are developing or thinking about what to do about it, what data do they need that we could provide that would lead them to say, where is the most best opportunity, or where we hadn't thought about that. Did that make sense?
Yeah, it does. It's
Okay.
not, there's no easy answer. Right. Yeah.
Yeah, Alan and then Jeff, this is your job.
Alan, go ahead.
Oh.
You were first.
Thanks. I think that ties in with the first bullet point here on the slide, to support policy.
Yes,
So what's the range of policies
right.
that the legislature might be considering this year or in future years? And also, and this ties in your point about cost increases statewide versus benchmark, but also since people tend to face outside of the connector subsidized plans, fixed dollar co-pays, fixed co-insurance percentages, regardless of income. One clear policy would be income adjusted out of pocket. So in addition to bringing your health insurance card, you bring in your income tax form. Or
Oh, but that solves the
demonstration of
consumer side, but it doesn't solve the employer side.
right. But I think that given that we've been discussing also, I agree with you, we've been discussing also data on different groups of people.
Mhm.
Just like we differentiate hospital profitability in the previous presentation, we can differentiate affordability for different clusters of people. Our family doesn't think about the $35 copay to see the family doctor. I know a lot of students who think about the $35 copay every time.
Right.
We all.
So what do you need to know?
Well, I would just add, I think there's two different topics here interrelated. One is the affordability for consumers and what is the total cost of care.
Right.
And we can do a lot to reduce the affordability for consumers and do nothing about the underlying cost of care.
Right.
And so, but I do think that there is a need to tackle both many times, because sometimes the lack of affordability can lead to an exacerbation of condition, not managing your chronic disease, which can lead to, increased spending down the road. I think the affordability, I will just say, this survey is one of our key tools that we use at the Health Policy Commission. Because I think it's important to reflect that there are other interested parties within our healthcare political environment, and who have very loud voices.
Yeah.
If you look at a recent State House News Service article that talked about the amount of dollars going into lobbying on Beacon Hill, the top 3 sectors were healthcare, pharma, and I forget the third, but it's definitely healthcare related, maybe the health plans. So how do we bring in the voice of the people who actually are paying for healthcare? And I think these surveys are really powerful at bringing that into the policy conversation. For policymakers, we're only going to be hearing from voices who say we need more money. And this is a way of getting at the voice of people who are saying we can't afford this anymore. And we're not able to access the care that we need. We're not able to access the drugs that we need because of the cost of care. So I think this is important. And I think, Ashley, you're kind of getting at this from narrative and a storytelling point of view, to encourage our policymakers to take on some of the more difficult political challenges that come with getting at the underlying cost of care. And I think there is a good example earlier this year where that happened. Massachusetts legislature passed 2 big healthcare bills at the end of the session. And one of them is completely focused on pharma. And so some of that was around capping copays for certain chronic disease medications. Part of it was also about establishing within the Health Policy Commission a new dedicated work stream that's going to be focused on making policy recommendations around pharmacy spends and trending overall. That for the first time, pharmacy manufacturers and PBMs have to come and testify under oath at cost trend series. For the first time, PBMs are going to be forced to be licensed by the Division of Insurance. So these I see as legislative reactions to the database and evidence base that CHIA and HPC have been putting together for many years now that says we got to do more in the pharma space. And I think the key legislators behind that have said, we still know we need to do more. And they've said that that's the first step. The last thing that I think does tie these things together, which I think is really, really interesting, is that the law also requires, for the first time, the Division of Insurance to consider affordability when reviewing health insurance rates. And that was not a factor that was in statute before. And so they came out with a policy this year that's going to be trying to reduce the growth in out-of-pocket spending. But I think there's a greater opportunity through this work with CHIA and the combined work that we've been doing to help inform how does the Division of Insurance think about affordability when reviewing health insurance rates, and with the potential to deny rates, if they're not going to be meeting some of these standards. So that's another kind of new tool in the toolbox that we have that we didn't even have 5 months ago.
Sorry, go ahead.
No, I was going to change the topic, so if you're going to go on that, go ahead.
No, I was going to say, in regards to the affordability piece on the rate filings, that is something that we just issued a filing guidance by the Division of Insurance that requires carriers to specifically identify the affordability piece as part of their rate filing, how they are specifically addressing it. So they've got some statutory figures that they have to address that are in existing legislation, but this really adds the affordability piece for the first time that's going to be addressed, that will help the division identify what are the other components of their rates that they're setting. And the division will have the ability to hold hearings for any rates that are deemed excessive. So I think we'll see that coming for the first time in a long time this summer. And so I think I'm looking forward to seeing what the actual makeup is of the various components of the rate filing, aside from what we've typically seen. This will be a little bit of an add-on. But the other thing I wanted to say real quick, just to Jean's point about how everything fits together, is the PACT Act that you were mentioning earlier. really relates to, again, the consumer side of reducing cost sharing for chronic disease, medications, things like that. But I'm also curious to see what effect that being implemented has on the overall cost of the healthcare system again. So, it affects one side, but how does it affect the other side again? In terms of the total healthcare expenditures, I'm guessing that's gonna not necessarily affect the total healthcare expenditures. It's just going to affect the consumer side, which is of course a huge aspect of it. But I think the larger question is, how do we address the picture as a whole?
Thinking ahead to the next time you field the MHIS, I think that there's a very good chance that Medicaid and the marketplace plans look a little bit different in ways that increase interruptions in care based on things that Congress is talking about, based on a proposed rule, proposed marketplace integrity rule that is currently in the comment period. So you mentioned that the MHIS is a way to get at partial year, people who are partial year uninsured. I think having questions that can drill down on that a little bit more would be great. If there's a way to learn, did you find out you were uninsured unexpectedly? So I've done some research around Medicaid unwinding, not in Massachusetts, but we did a survey in 4 southern states where we found that 1 in 4 people who lost Medicaid found out at point of care. Like, that's not how you want people finding out that they don't have their health insurance coverage. But if it's true that that's happening and they're finding out at the pharmacy, we want to know that, because those are potential points to connect people to care. And this, obviously, it is at the intersection of access and affordability. But if you show up at the hospital and you've lost your connector care plan, you generally can't get retroactive coverage, right? Like, your coverage to re-enroll starts the first of next year. So you're in this affordability gap. So I think thinking ahead, if we're in a world where coverage interruptions are more frequent as a matter of policy, despite the best efforts of state policymakers, how do we want to think about capturing that? We have a little bit of time since you're in the field now, and it won't be in the field again for 2 years, which I do appreciate that. Biennial, because I could never remember that one. I think that is something that's very top of mind for me. And I think it's worth thinking through critically, like, how can we evaluate that? And even now, what sort of baseline measures of gaps that we observe can we document to see if they change? Do we observe increased gaps in the ADCD where we see people transitioning from Medicaid to connector care or back with and without gaps? Thank you. That's really helpful framing. And we can certainly even just take that sort of viewpoint in when we look at the data from this current survey and set ourselves up for 2 years later.
And just, I'm sure you probably do, because I think it's standard federal question wording, but do you ask about like delayed and skipped doses of medication, things like that? Because that's a way of getting at access. That's not necessarily, did you try to make a doctor's appointment, but did you delay your care? Did you delay your meds? Did you skip medications? Do you guys ask about that?
That's not my team. I'm going to phone a friend.
We do ask about for-bill care, but we do hinge upon for-bill care due to cost. Okay. So we currently do not ask about, did you just forwent your medication? Okay. Just like open-ended as such. It is tied to care. I mean, in regards to your question about really about churning between insurances, that is something that we've been tracking over the years in MHIS. So we do ask about, currently, do you have insurance? Whether or not you also did you have insurance 6 months ago? Yeah. Insurance 12 months ago. So we do have some data in terms of, are people gaining insurance in the past 12 months or have they lost it? I think the details of which, whether or not you went from connector care to mass health or mass health, that is a level that currently we do not ask about, just because the current survey is very long.
No, I get that. You can do some of that, obviously, with limitations using the APCP data. I do think it would be interesting to know more about, did people lose their coverage without realizing it? So it's one thing to say, like, I was uninsured, but did they realize they weren't insured, or did they learn when they went to seek care? I think that that's a really important distinction that's not well captured in the literature anywhere.
Definitely to consider that as we think about the next round of MHAS, which will be here before we know it. And we'll definitely sort of bring it back, and we'd love to get your detailed thoughts on it as we're spelling out the questions.
And I just have one additional point. I think some of the enhancements you're making already are really great. I think understanding geographic variation, I think is important. So kudos to all of that. I think, again, as we're thinking about not this survey, but the next one, we were talking about earlier about people who are paying kind of out of pocket for different types of services and people paying cash for behavioral health. Primary care is another space where I'm increasingly concerned about people going to full concierge model where they're paying membership fees that may be in addition to their insurance, but there may be a way to start tracking and understanding how many people are paying significant amount of money just to be able to access primary care.
Related to that was direct primary care.
Yeah.
Great. I'm gonna wrap it up unless there's any other burning questions, thoughts? Terrific. We look forward to hearing more. Thank you. Primary and behavioral, two topics to just move on. We're going to switch to topics. Segue, yes.
So the next agenda items go through our priority areas. Caitlin's going to present the latest and greatest on primary care and behavioral health. But we are at a juncture where, as we think about building on various metrics to evaluate and assess primary care and behavioral health access and affordability, we'll be pausing at the end of the update to solicit your feedback on some of the similar questions that we were asking in regards to affordability. So with that, I'm going to Caitlin.
Thank you, Lauren. Good afternoon, everyone. My name is Caitlin Sullivan. So I'm going to first talk a little bit about our upcoming primary care behavioral health reports. And then, as Lauren said, open it up for discussion about some additional areas that we can investigate. So in the next few months, we're going to release 3 different types of reports on primary care and behavioral health. So the first one will be our primary care and behavioral health spending report, which is slated for next month. This report examines trends in spending for folks with private commercial insurance, Mass Health, and Medicare Advantage, spending on primary care and behavioral health services trending from 2022 to 2023. New in this report, we have the total Mass Health population. So we're really excited about being able to fully capture that population. And in the last iteration of the report, we could only look at managed care. So we have a little bit more expansive view into the total Mass Health population. And this will include some deeper looks into primary care as a result of the primary care subcapitation program that began in April 23 that Molly mentioned in our annual report. This report also includes some stratifications by insurance category, which I mentioned, as well as patient age and service category. So that's the spending report that is forthcoming. Then we have 2 dashboards that will be coming out in June. The first is our primary care dashboard that we've published for a few years now. This includes new data for most of the metrics, new data years, and it also includes 2 new quality measures on chronic disease management. So controlling high blood pressure and HbA1c control, both of which are HEDIS clinical quality measures. We also have a new measure included in our dashboard that examines the share of Massachusetts residents that received care at a community health center in the past year. Also in June, we'll be reissuing our behavioral health dashboard. This is the second iteration of our behavioral health dashboard. So it's similar to the prior year, except with all of the data points moved a year forward. We do have one new measure that we're including, looking at the number of members with a mental health prescription. Next slide, please, Alex. So looking ahead to the future cycles, we're already working on some additional potential metrics and sourcing. So at the last meeting, I know the council discussed several measures of primary care that you'd like to see CHIA measure. And I know we shared with this group an inventory last month of the measures that we either currently report or are in the process of developing methodologies to support. So I want to highlight some key new measures that we're working on as a result of those conversations. So for some measures, we're planning to use the all-payer claims database to develop metrics. So specifically looking at the number of primary care providers, So our current primary care dashboard does include the measure of PCPs per 100,000 mass residents, but that's at a statewide level. And as we've talked a little bit about, it's important to look at geographic variation and differences. So we're planning to use the APCD to look at primary care utilization and the number of providers on a more regional basis. As I said, we're also going to be looking at the visits per year per region, and I think we'll be hoping to include those two data points in the next iteration of this dashboard. Currently in the field is our primary care workforce survey that my colleague Haley will speak to, I think, later in the presentation. That survey is going to include a couple new measures that we are really excited about to include in our primary care reporting. Specifically, we're expecting it to provide some insight into the ability of providers to accept new patients, as well as wait times for new appointments, which are our two, I think, measures that this group talked about when we last discussed sort of measures of interest in the primary care space. We do have some information from our joint collaboration with the Health Policy Commission around the largest provider organizations and their payer mix, which we could consider including in future reporting as well if we think that's of interest. So to wrap up where we're going on primary care, the primary care task force will be having its first meeting in April. We're excited to support that, and we're looking to that group as well as to help guide us into the right frame for the measures we should be looking at in primary care. So on the behavioral health side, we are also planning to use our all-payer claims database to enhance some of the current measures that we have, looking at data points more granularly by member zip code, region, and the like. Drilling into some of the measures that we look at an aggregate level, such as like the service category, and understanding a little bit more about where people are getting care, at which types of providers. And I think this will also allow us to understand differences among different health plans in access. We'll also be looking forward to collaborating with the Health Policy Commission's Behavioral Health Workforce Center and working with our colleagues there to think about other ways that we should be reporting on behavioral health to make sure we're measuring what success looks like for the system. So I think those are the kind of where we're going in both primary care and behavioral health. And just as we discussed with affordability, this is a point we'd love to get the council's input into. In addition to these new areas that we're forging ahead with, are there other areas that we either previously discussed or that y'all have been thinking about that we should consider looking for new data streams or including in our public reporting going forward?
Thoughts? Did a lot of conversation last time, maybe. I have a quick question.
Yes.
How do we cut places like CVS Mini Clinic or One Medical and?
It's a great question. So in the way that we look at the spending data, we ask the health plans who report to include those if they are billing the insurance. Where we're not capturing is like the direct primary care or the concierge models that David mentioned before. So like the CVS, the Minute Clinics, those types of places, that's included, but the APCD analysis is where we'll be able to point those out explicitly. Right now, we can say, okay, this is how much we're spending on primary care. We're not able right now to say like, this is where or the type of facility or organization from which people are getting the care. So the APCD will allow us to be like, this is where people are getting care at Minute Clinics. This is, how many people or the percentage of people that are getting care at a traditional, primary care, as long as it's covered by insurance, so they're using insurance to pay for it.
So all of those are considered primary care sites?
They are for particular services.
Okay, no,
Yes.
that makes sense.
Yes.
I think they are used as primary care sites.
Yeah. I think another area that we'll want to look at is for sites like that, you know, there's been a lot in the last couple of years of closures of those types of, like, where people are getting primary care at a Walgreens or a CVS, and then those organizations close, and where those closures are happening. That's something we've investigated before, and I think, again, that's something that APCD can allow us to look at a little bit closer.
Other questions? She did the first.
Sorry, I couldn't put my blinders on. One thing that's come up in conversation recently is that, you know, many women essentially use their midwives or their OBGYN as primary care, and is that caught in this data? If you may refer.
It is, yes, that's a great question. So we do include, if you receive certain, like what we would say, like preventive services from your OB-GYN, we include that in our primary care definition because we know so many people get some of their like primary care from what we exclude is like labor and delivery, or the bundle of like the labor and delivery. So we do try to capture when that is happening. Again, because our data is so aggregate, we can't look at it specifically, and that's where I'm, again, excited about using our claims data to look at a little bit more closely at that.
To get at primary care FTEs, caregivers, the idea of visits per primary caregiver that you mentioned, I think will be very helpful. I forget whether the all payer claims database permits this, but so if you've got visits by zip code of site of care, can you back out and apportion people to zip code of residence?
Yes, so we do have the zip code of the member, of the patient, and the zip code of the provider.
Because once you have both, sorting it both ways could reveal very different rates of use of primary care, maybe availability or affordability of primary care by zip code. And I think along with zip code demographics.
That's interesting. Thank you. That's really helpful.
Are you able to capture telehealth visits distinct from other types of visits? Because like if I go on ZocDoc, I can get sometimes a primary care appointment with somebody pretty far away, but same day, right?
We do have like a separate category for telehealth visits. Again, we don't know, in our current reporting, I don't think we know like who the provider of that visit is. I think we just know sort of like, this is how much was a telehealth versus an in-person. Can I ask, like, what would you want to know more about that?
I think I'm just curious about, especially sort of post-pandemic, I feel like a lot of folks have shifted to being much more comfortable with telehealth. Like if I need a prescription, say a UTI or something like that, I don't necessarily want to have to go into a clinic to get that. And I don't think that that's like wrong or bad. I just think that there is research on this. I don't know that you need to duplicate what's in the literature, but just I think it's interesting to learn what the trends are and what the implications those trends have for costs, good and bad.
Yep.
You might have more demand when you make it easier to get care. So that's going to increase costs, but maybe the cost of delivery is lower, and having areas with fewer providers isn't as much of an issue, and telehealth at a distance is an option. I also don't know as much about the role of telehealth and behavioral health care beyond all of the ads on my podcasts or like BetterHelp or whatever it is, which I imagine is also cash pay. But I think that there's just, it's clearly been a trend. And I think understanding what that has meant for affordability and costs is important, to the extent that that is captured. And I actually don't know how that's recorded in claims. So
thank you.
And I was going to say, actually, I was thinking that in terms of behavioral health, where it is tremendous in terms of creating access and, you know, I mean, the transition during COVID to behavioral health online was huge. So I think that, I was going to ask sort of the same question is, can you track that?
We can, and it's sort of the same. I think we're able to see telehealth, behavioral health, and we've seen a huge uptick in that when it's covered by insurance. For these other types of like apps or services that are like outside of the insurance relationship, that's where I think we have a gap in our data that I think is important to measure, that I think we can start exploring or using survey to try to get at.
So on that point, you know, because I was just thinking, what about artificial intelligence? What is its role in particularly the primary care space and the behavioral health space, complicated as it is, I think some kind of movement is going to be inevitable. So obviously, I'm just thinking the data is just, we're not going to be able to see it. But the survey that we just talked about, should we consider incorporating some questions around the market's readiness in sort of accepting some kind of algorithm-based technology in place of human sort of treatment? Because I think primary care and behavioral health, the data is going to continue to show very, very concerning trends. There's almost the question, how do we get out of it? And there is the question, is there a significant role to be played by technology? And is that something that we should proactively think about? Again, just from a policy standpoint.
And I'll just add, for the council's edification, again, as part of one of the bills that was passed, there's going to be a new primary care task force that's being set up. It's a 25-member task force with representatives kind of from a broad range of different layers of expertise in primary care. And it's a pretty ambitious charge for this task force, but it's going to be tackling some of the very questions that you guys have all brought up. One of the charges is around defining the codes and services that is primary care. I suspect and I hope that we will look to our friends at CHIA, who will put a lot of work into defining the codes and services in primary care and have been measuring that as our first place to go for something like that. But it also talks about what do we need, what adjustments need to happen in the workplace, what adjustments need to happen for the workforce. AI is definitely going to be a part of that conversation. And finally, the law does have a role where the task force is charged with consulting with CHIA on any data reporting requirements that may be necessary for the task force to do its work, and gives a broad mandate to CHIA to promulgate regulations and collect reporting pretty broadly from payers and providers if that information will be useful for the task force. So I'm a co-chair of the task force along with Dr. Mahania from UHHS. Director Peters is a member of the task force, and I think we are going to be working really closely with CHIA, given your level of expertise and the great data that you have.
This is a question based on this conversation. The definition of primary care, so many of us think of my nice doctor, and I go to that doctor, but people are going to OB's part, CVS for some, teledentistry for some, believe it or not, and telemedicine. How do we think about it this is, I guess, a question as we go forward, because I see these trends all merging in different ways, and the mindset we have is, and probably even just what you said, our first thing we're going to do is count the number of PCP physicians. Well, that may only represent about a half, 40%, 90%, I don't know, of the care that's actually delivered that we define as primary and dental.
Yeah, I mean, I think, as Caitlin said, we can get a lot of information if you're part of the insurance system, right? We can know what the services are. And so that's really how we're categorizing primary care. What's the modality of that service? Where is that service taking place? Those are a little bit trickier questions, right? And I think, as I heard you're trying to answer those and fill some of those gaps.
Yeah. So add it to your list.
Yeah, but do you want to just speak to the hierarchical sort of definition that we use now, sort of looking at first? What was it?
First is behavioral health.
Yeah.
So it's going to be your last conversation.
Okay. I'll try to do it quickly.
Obviously, what everybody's interested in.
So the way that our methodology works is we look at sort of primary care and behavioral health together, where we have a hierarchy. So when the health plans report the data to us, they look first at, does the member have a behavioral health diagnosis? If yes, what services have they received? If the services are delivered by a primary care provider, they're put in a bucket that then we can say, we're considering this primary care or we're considering this behavioral health. Then if they don't have a behavioral health diagnosis, then it's what are the services they received and who delivered those services. So that's where they might receive something that could be delivered by a family medicine doc, but also an OBGYN, right? And those would be considered primary care. So we use the hierarchy to sort of have a combination of the services provided and who provided those services as the way to identify primary care. But to your point, I think there's a lot of there's a range of ways people are accessing primary care. And I think we, in our, the great thing about CHIA is we have different types of data sources that can help us answer some of those questions beyond just the claims data.
And I just want to add, because I think, when you say somebody has a diagnosis, I mean, I know, based on my experience at an FQHC, 60% of the patients had a diagnosis that they were coming to the PCP for. So it sounds sort of like, well, wait a minute, why would these, but that was, the vast majority of patients actually had that diagnosis, and yet it was primary care. Not behavioral health.
Fascinating topic. Thank you.
Thank you.
Everybody move on to another incredibly important topic, conventional capital.
Sure. I think just a quick TF. I think folks are familiar with our general health equity strategy, the framework that we're using to really hone in on certain areas and expand the work of health equity that we're currently reporting on through new stratifications. Haley will speak to two particular kind of strategies within our broader 5-point health equity data strategy. So without further ado, I'll hand it over to Haley.
Awesome. Thank you so much, Laura. Okay, so as part of efforts to advance the agency's overall health equity goals, as Lauren just mentioned, we have our 5-point health equity data strategy, and I'm here to update you on some work that's underway for 2 of the 5 sort of key points that we're looking to advance. The first one is regarding advancing the health equity goals that we have by better communicating results of our analysis to amplify and increase the impact of CHIA's reporting. And as part of this goal, we're developing a health equity dashboard, which is going to aggregate, amplify, and increase the impact of CHIA's existing inventory of health equity work. This dashboard is a cross-agency collaboration and effort, and it aims to centralize a lot of the key findings that have been published in previous reporting that highlight resident disparities in the domains of coverage, access, utilization, affordability, finance, and quality of healthcare services. The format of this health equity dashboard takes its inspiration from some of our previously published dashboards in the primary care and behavioral health space. And users or readers of this dashboard are going to be presented with descriptions of each key domain, findings related to those domains from our existing reporting, and a link to the full report where those key findings were sourced from. And our intention is to update this dashboard periodically in the future as we have new findings to share, and as sort of new analyses and enhanced existing analyses that include a health equity lens are published. Another point in our key sort of equity data strategy is to focus and coalesce our analyses and reporting in 3 topical areas that you can see here. To improve our reporting, promoting equitable access to affordable care, we're going to be expanding our TME analysis to include separately analyzing cost sharing and exploring the relationship between community sociodemographic characteristics and the prevalence of chronic disease. And that might take the shape of top diagnosis codes by geographical areas. Regarding equitable access and utilization of timely care in appropriate settings, CHIA is going to continue its reporting on avoidable ED utilization and on readmission trends by sociodemographic factors, as well as updating some of our clinical quality reporting to stratify certain measures by race and ethnicity. And to improve reporting on the financial viability of safety net providers, CHIA is also going to be applying that equity lens to its relative price analysis. Providers, in addition to hospitals, will be included in the analysis, and it's going to focus on lower paid providers with high public payer mix, low commercial relative price, and providers that serve diverse communities. But certainly, I think we're open to this group's feedback on any of those sort of planned analyses or enhancements, as I outlined. Given the current federal landscape, I think we just wanted to distinguish the concepts of diversity, equity, and inclusion from our planned equity-related work. CHIA strives and intends to support the Commonwealth's vision for an equitable healthcare system where no one is disadvantaged due to socioeconomic status, or socially assigned circumstances like race, gender, ethnicity, religion, or sexual orientation. And our planned analytic projects aim to be a reliable and meaningful source of information for all residents as we move towards achieving this goal. As such, I think we were interested in discussing whether or not there were sort of other metrics that this group believes could be included in some of our reporting, sort of beyond the additional sociodemographic stratifications that I mentioned. You know, are there ways that we can better incorporate other metrics into our existing reporting?
So.
Yeah, that's our discussion, our first question, sorry.
Okay. I think it'd be really helpful if anybody has any experiences they could share on collecting sociodemographic data, for example, all the issues people are facing that could be helpful to CHIA as they move forward. We all feel like that, I get it. Any other thoughts?
I mean, I would just say it's incredibly challenging, because people don't, you know, in trying to collect all of the data, people don't want to answer the questions. People don't, you know, I think that this is a challenge across anyone who is trying to collect that data. People really don't. And so then you end up with folks trying, you know, your staff trying to determine it based on people's names or what they see. And it just is not, you know, so it's really hard, but incredibly important. So thank you for your focus on this.
Any other sort of topical areas that we should be focused on in addition to the 3 that we saw in the previous slide that this council is interested in?
Can you just clarify, when you went over the financial viability of safety net providers, I think you said that this would be a change to the relative price analysis with kind of an equity lens?
Yeah.
What is, do you have a sense of what that looks like?
Yeah, no, that's a good question. I think we sort of met to discuss ways that all of our existing work could be enhanced to better include a health equity lens. And I think one of the ways that we felt we could do that was for our relative price dashboard and work. I think we were interested in adding other types of providers in addition to hospitals and physician groups into that analysis so that we could sort of include those providers that have a high public payer mix or a low commercial payment rate to sort of speak to financial sustainability and patient access to care. That was the intention by including those other providers, but certainly I would turn to my other CHIA colleagues to speak more in depth to how we're planning to enhance relative price work.
Yeah, I think the main thing that I would say, Julian, is like we typically focus our relative price, like public reporting and key findings on the higher priced providers who are receiving like high commercial rates. I think what this is sort of like flips that and looks at those who are receiving low commercial rates and who are the communities they serve, like geographically where are they located, where are those hospitals or provider or organizations located, like from a geographic basis, and who are the populations in those areas, and focusing a little bit more on that end, and then especially ones that have a high public payer mix. What do their commercial rates look like? I think we know from many years of relative price reporting that those that have a high public payer mix tend to have a low commercial prices. But I think it's more about shining a spotlight on those providers.
Okay, thank you. That's helpful. So it sounds like this is more a question of narrative and focus and less about changes to the RPA methodology.
Yes.
Exactly. Expanding the providers that might be captured.
Exactly. That's right.
Thank you.
But maybe to complement that a little bit, what if a given health center or hospital, what if we had the equivalent of site neutral payment, which Congress keeps talking about for primary care? What if we looked at, say, all 58 hospitals and suppose that their revenue, net patient service revenue, were paid at the statewide average across payers? Who would be the winners and who would be the losers? In other words, by that measure, which hospitals are being, and this could be case mix adjusted, of course, which hospitals are being overpaid and which are being underpaid. It's one maybe simple-minded, possibly too simple-minded, single metric of fairness of payment, equity of payment. If we worry that Medicaid patients, for example, sometimes have trouble finding doctors who'll see them. But if all payers paid the same price for the same care, which somehow is supposed to happen in a free market, as a benchmark.
Yeah, I think it's an interesting question. I think that we know that, sometimes affluent communities are served by affluent healthcare systems. And I think that speaks to, a little bit of how care is patterned, generally speaking. So it's an interesting question. I don't know if that's something that we would sort of consider adding a relative price, but it's a good point.
It might be quick and dirty and relatively easy. Of course, it's easy for me to spend your time. Also, there are high-income places like Concord, which, owing to maybe low use rates and other things per citizen, have relatively low cost of care.
We can certainly take that question back and look at what we can do with the data that we have.
I apologize if I missed discussion was at prior meetings or don't remember it. Is there anything in the measures that captures something approaching cultural competence or like how comfortable marginalized communities feel with the providers that they have access to? Because I think it's one thing for us to measure spending, utilization, all of that, but I think a lot of equity considerations are more intangible.
Yeah.
And I recognize that like we can't solve everything with the survey. It's very expensive to solve problems with the survey. But I'm just curious if there's anything that you're tracking that gets at those sorts of questions. Can you see the sort of provider you'd like to see, whether that's racially concordant, somebody who is supportive of your LGBT, life? Like, do we have anything that gets at that?
So the first thing that comes to mind is our healthcare workforce survey, which I'm going to talk about next. The intent of that survey, I think, was to first understand the capacity of different healthcare sectors to sort of meet the demand, the utilization demands. Do hospitals have enough staff? Do they have enough nurses? Those types of questions. But the second part was to understand the diversity of the staff that are employed at those facilities, because we know that concordance improves health outcomes. And so that's an organization level survey that we field to get an understanding of kind of all staff, race and ethnicity if it's available, but we also ask about race and ethnicity of key providers or key occupations in each one of those sectors. I think to start to maybe chip away at questions like that. We field a sector specific survey. It's kind of like 13 surveys in one survey suite. And there are some sectors where we do ask about languages of services offered to try to, I think, again, chip away at that question that you have, but it's a good one.
So unless there's something burning, I'm going to move the agenda along.
Okay.
To talk about workforce.
Perfect.
And make sure that you're not.
Okay, perfect. Yeah, since we've already gotten started a little bit, the 2025 Massachusetts Healthcare and Human Service Survey is now in the field in 12 of 13 sectors, including acute care hospitals, adult day services, community health centers, nursing homes, ambulatory surgical centers, emergency medical services, home care agencies, behavioral health providers, behavioral health hospitals, human service providers, primary care practices, and public hospitals. And the survey actually launches next week in dental practices, so that's great. If you remember, we fielded this in 2023 in all of these healthcare sectors, and it was the very first time we fielded this. We learned a lot in the process, and so we've incorporated some of the lessons learned from that inaugural survey into this cycle. And we used a lot of feedback that we got from provider associations, from state partners. That was all incorporated into our revised survey instruments, really with the goals of improving response rates, improving data quality, and improving how actionable some of our findings can be. These surveys are going to remain in the field through June 2025. The data will be cleaned and prepared for analysis this summer, and then the analysis will begin in early fall. We expect, like last time, our sector-specific and cross-sector analyses that we have on our website right now in the form of the dashboard will be published in January of 2026.
Okay. This was an easier one. This is new.
It was, yeah.
Yeah. But if anybody has a question or has anything they want to add, please. Great. Thank you very much. Thanks. All yours.
All right.
Martha.
Yes. So I'll just start with sort of two items at the top. One, I begin by acknowledging the many changes and announcements coming from the federal government, including the elimination of 10,000 HHS jobs today. So we at CHIA, we're working with our sister agencies to monitor these developments and assess impacts. To date, CHIA has been fortunate. We have had no direct impacts to our work or funding, but we do expect some of these changes to have material impacts on some of our sister agencies, as well as hospitals and payers in the system. So we'll continue to monitor the developments, and we'll certainly keep the council apprised, especially if there's any sort of direct impacts to CHIA. I also wanted to just acknowledge, as the auditor's report came out in between since our last council meeting, I think many of you probably read about the report. I know we sent out a communication, but essentially in early January, the Office of the State Auditor conducted a routine performance audit of CHIA, which is a part of a process that all agencies undergo roughly every 3 years. The audit was focused on our Compare Care site, as well as sort of our role in monitoring the financial performance of hospitals. The process has now concluded, and there's no further action for CHIA as of right now, but the findings did highlight a couple of areas that I wanted to just call out and acknowledge today. One was around opportunities to expand our Compare Care, and a sort of emphasis on publicizing the website, making more available to individuals with disabilities, and bringing it into compliance with web accessibility standards. So we are actively sort of taking the feedback and evaluating options for the website. I think part of the reason that we haven't been investing a ton of money into marketing and publicizing is because I think that we've generally understood that, and based on data that we collect on website hits, there's really low utilization. And I think there's sort of research and literature suggests that these shopping tools, healthcare shopping tools, are generally not utilized to the extent that I think at one point folks wanted them to. So we are looking at sort of other states, other best practices to hopefully evolve the website into a more useful tool. It may look a little bit different than what it does today in terms of comparing prices, but we really want to understand what are the just key decision points in someone's healthcare journey, from choosing a plan, choosing a primary care provider, and really leverage those as to help inform how we sort of develop this website 2.0. And as we progress in our thinking, we'll certainly bring that back to the council for your feedback.
I think all the available evidence is that these websites are really dumb ideas. And I think anybody who works on it is going to feel, I imagine, will feel pretty alienated going through the motions to comply with a state law that at best could be described as wishful thinking, or a substitute for real cost controls, asking patients to inform themselves so they can be good kamikaze pilots in the cost control war, asking the weakest, least knowledgeable people to contain cost. And I think that it would be worthwhile, at least for ourselves, to discuss the possibility of saying, we wouldn't wrap fish with these data. And why ask us to do something that's useless?
I don't disagree with a lot of the sentiment, and I think this website is statutorily prescribed.
Yep.
And so I think we're, absent a change in statute, we're considering options to evolve, and it's not definite at this point. But we are considering options for evolving it to actually help inform some of the decisions where we do know that there is a lack of information and knowledge out there. It may not be around price, but it's something that we're actively looking at. And we'll come back to it once the thinking is further along.
If there are high payoff, low cost activities that don't involve trying to drill through granite with a piece of wood. Sure.
Right.
But I think it might be worth a conversation off the record, if that's legal, with relevant committee chairs at the State House. If maybe those have already happened and they're futile, I don't know. But futility is.
Right. Well, that's precisely why we haven't made investments in marketing, advertising, as the report called out.
But I like the idea of, unless there is some other big change, trying to figure out what we can do that is actually useful. As you said, you're thinking about, that is a terrific idea. Because there may be something other than looking at the price of, I don't know, my test for vitamin D, which is about, I agree. I think it'd be an interesting conversation to bring back to the team. Yeah.
So the other sort of scope or topic of the auditor's report was around hospital monitoring. The report called out stewards' non-compliance with data submissions, that reasonable extensions were given to providers in their filing deadlines, and that CHIA exercised its discretion over when fines were necessary to ensure compliance with the reporting requirements. The report also raised the question of CHIA's obligation to report on hospitals in financial distress and the closure of essential services. And I would just note that CHIA has continuously and on a quarterly basis convened a group of relevant state agencies to review data that's included on our public dashboards, including things like financial performance, utilization trends, and other contextual information that's helpful to inform whether additional action is necessary. So that quarterly convening to monitor based on data that we collect here at CHIA, and that again is available on our dashboard. That is sort of, in our view, the most efficient way to fulfill its role in monitoring hospital financial performance and stability, while satisfying the public purpose for which that requirement was intended. I know we received questions from a council member and sort of an interest in discussing this in a little bit more detail. So I turn it over to you. I know based on a question from, I believe that arose from the auditor's report.
Yeah, I think this is the only area of the three raised in the auditor's report that has any real merit. I don't think the other two do, for reasons you've discussed, that others of us have discussed. We had 141 hospitals when President Kennedy was elected. We're down below 60, depending on how you count. When Leominster Maternity was going to close, there was a lot of upset and turmoil, and it was pushed through, and things quieted down. Individual hospitals often close quickly without much community awareness, and certainly without time for relevant people to organize. It might be that using existing CHIA data, identifying hospitals by their risk of closing in the next 5 years. We've talked about there are short-term models that use accounting data, mainly in payer mix data. Others, there are medium-term models, 5, 10 years down the road, that highlight the kinds of hospitals that closed in the past, predicting with surprising accuracy, 80%, which hospitals are likely to close in the next, say, decade. And matching that against potential need for the hospital, travel time, alternatives, affordable care. Also the risk of doctor displacement if hospitals close. To say that these hospitals look like they're at risk of closing, it looks like they're needed. These might be the kinds of hospitals that the legislature and different state government departments could look at. The way a dentist tries to identify early signs of decay.
It all comes back to oral health.
It all comes back to oral health.
So
We can take a bite out of this problem.
So I hear you on the ask, and I think as we at CHIA, as we consider future options for further reporting on distressed hospitals, you know, we are constantly trying to find the balance of promoting that transparency with the potential unintended consequences of making that information public and the market reactions. Because the minute that a government agency identifies, even if it's a predictive model, if they're put in that imminent risk category, it will only accelerate the financial turmoil. And so I think that is an unintended consequence. It will essentially be manifesting what the concern is. And so I think that is a consideration that I think that we have to take into account when we're considering options for reporting and identifying. And I think at the end of the day, we need to think about what is the true purpose of monitoring the financial health of these hospitals. And is it just to put it out for public community knowledge, or is it more important that we have the relevant agencies that have the levers to be able to respond, to have that information?
I think you point to a delicate balance. First of all, anybody who is financially exposed in relation to the hospital, creditors, suppliers, knows exactly what trouble the hospital's in already. So I don't think they're going to stampede and demand certified checks at the loading dock if they haven't already done that. Second, over the decades, I've talked with legislators and others in state government about this. I've seen virtually no evidence of serious interest. It's growing, and it's better than it was, but it's still very low in state action to respond to crises facing needed but distressed hospitals. There's little interest in tapping the rainy day fund or in creating the hospital stabilization trust fund that's been proposed in legislation for over 3 decades. That would make it a lot easier for state to respond. But right now, no one really has the obligation to identify, let alone pay for, needed hospital care. And so the question is, are there ways of beginning to move that?
So I would say I'm totally ignorant about this, and don't understand the different agencies, as you say, that need to be involved in this. So it is providing data, early warning system to agencies. I mean, maybe there's something to think about that we should take back with us. And I'm going to ask you as an agency.
Yeah, no, I was just going to add, I think actually there's been, I think, some progress on this front in some of in the legislation.
Yeah.
So I'll just mention 2 things that I think can be helpful to advance this conversation. One, there's another task force which I'm going to be involved in, which is specifically around maternal health access task force, and part of the charge of that task force is looking back at those past closures. What were the impacts in terms of patient availability for care? And as we're thinking about doing that research, Dr. Sager, we're gonna be trying to think about like, what were the factors that led to that closure? And then can we use that analysis to say, what can we then predict for the future for other types of closures? You know, what were the characteristics of that hospital? What was the volume going to that hospital? What was the staffing like at that hospital? And the mandate actually charges us with making recommendations about the essential service closure process and how that might be improved. That's specific to maternal health. The other one is that in this law, it also revitalizes this idea of state health planning and charges the HPC with having an Office of Health Resource Planning that I think does speak to some, an analysis of where is the supply, where is it needed, where do we desperately need to hold on to that supply in those facilities that are serving important populations. And again, we have an opportunity to, make those recommendations about what are the policy changes that need to happen in those circumstances. Is there a place for state receivership? What would be the circumstances for something like that? So I'm personally hopeful that we're going to be able to leverage those, both the task force and then the ongoing office, to be able to be more proactive in our planning rather than just always being reactive when something bad happens, right? And I think that's ultimately like what we're trying to get to is how do we not just, there's a closure, now we're scrambling to fill services. How do we think about what the communities need, what patients need more proactively, and then put the policies in place to protect the really important ones? So I just offer that as new work for the HPC and look forward to engaging with you on it.
I thought you had a full-time job before. Seriously.
That was helpful, thank you.
Yeah, and it's true. But maybe I'm a little frustrated after 30 years. Because the progress is real, but from my standpoint, if a couple of hospitals in hypothetically Worcester County or Hampshire or others were to close, or were to, like North Adams.
Yeah.
Where the AG was from, violate the law and say, well, 90 minutes, not 90 days. I don't think the capacity is here yet. And I don't know how quickly it would be assembled.
Yeah. Well, we're going to be pushing.
And I'm sure at some point CHIA will be providing information and data.
Yes.
And I'm going to move the agenda along for some other important topics, but we'll keep this open.
Yes.
Thank you.
All right, and for the next slide. So I'll just try to zoom through the budget and legislative update. So in January, the governor filed her proposed FY26 budget, and it included level funding for CHIA at $33.6 million. So I think we are okay with the level funding, but since that time, since the budget was sort of developed and filed, of course, we have these two new pieces of legislation. So we've assessed sort of the impact and new resources that we'll need to implement those bills. We've submitted a revised request with a slight increase from the level funding included in the governor's budget. And I will be on April 7th, I'll be testifying before the Joint Committee on Ways and Means on behalf of CHIA for the budget request that we had submitted to the Ways and Means Committee. The following week, the Oversight Council will hold its statutorily required budget hearing, which really provides opportunity for stakeholders and the public to weigh in on CHIA's FY26 budget proposal. It's chaired by the A&F representative, but all council members are welcome to join if you're interested. It's typically pretty quick, as we haven't had anyone testifying in recent years. But I never know. You never know. Yes, you never know. So we would welcome all council members to attend. In terms of legislation, the new 2-year legislative session began in January, and over 6,000 bills were filed. This includes a number of new and refiled pieces of legislation with over 80 that reference directly or indirectly CHIA with the new directives. So, Emma will be busy sort of as we're monitoring those bills and tracking sort of major pieces of healthcare legislation that will have an impact on CHIA. And we'll certainly keep the council apprised of any developments on that front. So I know we've touched on them. If you wouldn't mind going to the next slide, thank you. The two major healthcare bills passed at the end of last session, signed into law in early January. Both include a number of new directives and responsibilities for CHIA. So the first bill was aimed at, as David has mentioned, aimed at increasing market oversight in the wake of Steward. In terms of new directives for CHIA, it expands our authority to collect new financial information from hospital and provider organizations, parent entities, significant equity investors, REITs, and MSOs. So we think that will help give additional and really important line of sight into some of these new market participants that are increasingly becoming engaged and involved in our healthcare system in Massachusetts. David already mentioned the primary care task force, which was also included in this bill, charged with studying primary care access, delivery, payment here in the Commonwealth. CHIA has a role, as David mentioned, CHIA has a role in the task force, and we stand ready to support and look forward to the first council or task force meeting next month. The other piece of recently enacted legislation is aimed around bringing down, or really bringing transparency and accountability to the pharma industry with the end ultimate goal of reining in pharmacy spending. Among several new reporting provisions, it authorizes CHIA to collect cost data from PBMs and directs us to include some of those cost and price trends in our annual report. So we look forward to working with our colleagues at the HPC and DUI, who also have roles in bringing that additional oversight to PBMs in the coming year. So in terms of both of those pieces of legislation, we're currently developing implementation plans and timelines for those new directives. And we will keep the council up to speed at future council meetings as we get various components of the new directives in place.
Do you anticipate that it's going to be a heavy lift?
Many of the new directives build upon sort of existing work. So for example, we're already collecting financial data from hospitals. We already have the sort of templates, if you will, to collect that information from hospitals and from registered provider organizations. Much of these new bills are built upon existing infrastructure. So while we certainly believe that we need additional resources to fill these, we do feel like we're not having to stand up wholesale new departments or teams to tackle these new directives. I don't want to understate though the challenge of being able to collect and really coerce these out-of-state parent entities to provide the required data. Like I think that it's going to be a challenge to identify them, draw the bounds and scope of who are these entities, where are these entities located, and really being able to collect data, get them to comply and get on board. But I'm confident that working again with our colleagues at the HPC, that we will be able to wrangle these entities in the coming years. So I think that's probably how I would summarize the temperature in terms of implementing these bills. You don't have to stand up anything wholesale new, but I think that the new reaching these new entities will not be without challenge.
Do we expect the PBMs are all going to comply?
You know, I'm more confident with the PBMs in part because under the legislation, there's a new certification licensing framework by the Division of Insurance. And the universe is fairly small. We know that there's really three main players in the PBM space and I think a couple of other smaller players. But because the universe is more defined and contained, and with these new certification licensure requirements, I think that they would be unwise to not comply because I think it would impact their licensure or certification status.
If they want to do business in Massachusetts,
Exactly.
that is.
Exactly.
Does this put us sort of pretty much right at the front relative to other states in terms of PBM transparency?
We actually know of a number of other states that are already collecting data from PBMs, which is helpful because I think that there's somewhat of a playbook there for collecting this information. So I wouldn't say that we won't be the first, but I'm confident that being sort of middle of the pack, that we can refine existing states' processes and become the best in terms of a quality on a qualitative basis.
Well, I hope this will be helpful in terms of the price competitiveness of our insurance plans. The transparency that is, although, you know, depending on how you think about it, I have reasons to be concerned it would be the other way around. So obviously we'll have to see how it plays out.
Yeah.
After Medicare negotiated prices for the 10 most expensive drugs, the remaining prices are still 3 times the Western European average.
Yeah, there's a long way to go. So how do we push them down?
Accountability is far away.
Jean, I would just add, I think where we are on the forefront and where it will require, I think, some novel thinking is on some of the more private equity focused reporting requirements. Defining some of, you know, significant equity investors, being able to collect information directly from private equity, you know, defining and understanding real estate investment trusts, MSOs. There's a whole novel and ever evolving financial ecosystem that is coming into place. And it is changing in real time. So you create a definition and they may find a way around that definition. So I think of the areas, I think as Director Peters said, on the PBMs, a lot of states have done that. This, we are really on the forefront.
That did come up, but not that I've been directly involved, but I know in regards to the licensing of the PBMs, that work is now just beginning. I know the division is tasked with creating regulations based on the law, and we're really creating like a beginning of a framework to what it's supposed to look like to actually license PBMs. The division is really used to licensing insurance carriers and HMOs. And so this is going to look different, but it's going to really piggyback off what that process is like for insurance carriers and HMOs and draw from existing regulations from those and see how we can draw from those to create new regulations for the PBMs. And one of those first questions is really identifying what exactly a PBM is and which entities actually fall within the definition of that to ensure that we're encompassing the proper entities that are supposed to be part of that.
Thank you for that. Yeah. Got our work cut out for us. It'll be fun. Yeah, those are going to be challenging. All right. So no other questions. I'm going to move right on to the EAPCD project. So since we last met, a few milestones have been accomplished. One, we've built the initial data models for medical and pharmacy claims in the Microsoft Power BI tool. Additional refinements in the user documentations are planned over the next couple of months on that space. Two, we've finished developments on 3 environments for data warehouse.
development, integration, and QA. And then the flexible analytics procurement for data enhancements and groupers, that the procurement is completed and the project has kicked off. So we anticipate it will be about 4 months until the flexible analytics are fully implemented. I think in short, with respect to where the EAPC project is, we are continuing to make progress and move the development forward, and on track to complete this by the September timeframe. So we're about two months, I think, behind where we were hoping to be in July, but we are actually gaining some ground, making up for some ground that we lost due to primarily sort of like contractor personnel hiring challenges that we saw at the beginning. But the project is largely on track, and we hope to have it stood up and running, full functioning in September. And then the final, actually, let me pause. The EAPC always gets skimmed over this slide, yes, but we'll have a celebration when it hits. And I look forward to that. The September council meeting. Yes, good idea. Now you've got real vote. Yes, yes, no pressure.
That was a quick summer.
Vacations.
Yeah. All right, and so the final slide just gives an overview of publications. So since the last council meeting in December, in addition to the annual report, we've released a number of publications, including the annual hospital-wide adult all-payer readmissions report. I got all the qualifiers there. We released the hospital fiscal year 23 hospital profiles report. The first inaugural nursing facility performance dashboard, as well as the latest edition of enrollment trends. In the looking forward, the next couple of months, we'll be releasing the next quarterly hospital and health system financial performance report with data through December 31st, 2024. We'll have, as mentioned, the latest report on primary care and behavioral health spending, as well as the CHIA health equity dashboard that Haley discussed earlier. I think that covers the next quarter. But any questions on the publications?
Lauren, what of any reaction did you get to the nursing facility transparency dashboard as that was new?
We received really positive feedback, primarily from Mass Health and some of our sister agencies, as well as the trade association, Mass Senior Care, and I believe the 1199 was also really interested in having this data aggregated, centralized, and available. So all in all, it's all been positive. And I think that the way that it's organized and again, centralized in one place makes it easy to get arms around all the facilities out there, and really make sense of some of the financial data that we're seeing.
Great.
Well done. Lots of things happening, amazing. You have 2 minutes left if anybody has any other comment, otherwise I will propose that motion.
Madam Chair, I just wanted to say one quick thing. I'm sorry, I know I've said so much, but I just want to highlight the importance of tracking some of the federal action. You know, today was announced in addition to the 10,000 layoffs at HHS, that the Agency for Health Research and Quality, ARC, is going to be reconstituted and consolidated to another office. You know, I think all of us here know the importance of data, and ARC is one of those key federal data sources that allow us to do incredible benchmarking from Massachusetts to other states into the country. And so I would just want to commend you, Director Peters, for keeping an eye on that. And I think we all need to keep an eye on these changes that will potentially erode our data understanding of our healthcare system.
Well, on that cheerful note. Is there a motion to adjourn?
So moved.
Second. All in favor, I just.
Thank you.
Thank you.